Hello guys, welcome to our channel. Today we are going to discuss about the orthopedics rapid revision for upcoming examination. So as part of our mission to 100 plus, we are going to complete this today with the all high yield topics and the PYTs. Okay. So even though orthopedics looks like very small subject, only 5 marks, but it is going to be play major role to boost our score. Okay. 5 marks is 1 mark is also matter for us. So please read this topic and revise with the MCQs. So let's start the discussion. So first, here you can see this is the normal anatomy of the bone. So you have the epiphysis and here the proximal epiphysis and the distal epiphysis. So this is known as a diaphysis, and between the epiphysis and the diaphysis you have this small midzone that is known as a metaphysis. And this metaphysis containing which kind of the bone, guys? It contains spongy bone. Okay, whereas diaphysis going to contain compact bone. Okay, because it is strongest bone. And spongy, here the majority of the growth plate that is present in the medullary cavity only. Okay, so this is what normally we are having in the bone anatomy. And bone have different kinds of cells. So for example, almost the bone is made of the what kind of cells, guys? Especially osteoblast. Okay, on osteoclast and osteocytes. So what is the function of these cells? So first, osteoclast is osteoclast is going to be work as a monocytes. Okay, or it is work as a macrophage activity or the phagocyte activity. Next, osteoblast. These osteoblast is going to be rich with the ALP. And what is the importance of this? So this will going to make the bone. Okay, so this is going to contains the ALP as a alkaline phosphatase, and always remember, so this is going to give the bone matrix. Okay, this is going to give the bone matrix. Next, osteocyte. These are very long and the most abundant, which will be containing and mature osteoblast. Okay, this is known as a mature osteoblast and longest lifespan, along with that abundant cells is present in the inside of our bone. So these three cells that you have to remember. Next, coming to the collagen. So what is the collagen that is present in the bone? That is collagen 1. And what is the inorganic matter? If they ask, the inorganic matter that is present is the calcium hydroxyapatite. Okay, so calcium hydroxyapatite is going to present in the bone as a inorganic matter. Okay, this is the things that you have to remember. Next, what is the matters that is present here? Like bone marrow markers. So bone marrow markers are going to be like procollagen. Okay, procollagen and osteocalcin, osteonectin, and we all know this is going to be the gold standard or the good marker. ALP is going to be also present. And next, hydroxyproline, hydroxylysine. Because why they are present, guys? Because collagen 1 is present. So that can be also positive markers. Next, coming to the healing. Here you can see the fracture healing is going to be in the 4 phases. Okay, first there will be hematoma formation. This is the stage 1. Next, in a stage 2, there will be fibrocartilaginous callus formation. This is the second one, which will be around 2 to 3 weeks. And next, third stage will be callus ossification. This is almost 4 months as stage 3. Next, stage 4, there will be bone remodeling after almost 1 year. So this is stage 4. This is commonly seen in the bone, whatever the healing that is present. Okay. Next, moving on to the complications. What are the complications which will be associated with the bone related fractures? We all know one of them is the non-union and other one is the malunion. So this is associated with the bone deformities. But if the fracture is happened, what are the other things can be happened, guys? First, bleeding manifestation, right? So if there is a profuse bleeding, there will be a shock. So hemorrhagic shock can be also seen in this patient. Next, fat embolism syndrome. So what is mean by the fat embolism syndrome? So if you see, fat embolism syndrome is usually associated with the major fractures. For example, femur fracture. Okay, femur shaft fracture also seen. So what is happening here in the fat embolism? The pathogenesis here is when there is a shaft of the femur is fractured. So this will cause the release of fat, okay, from the medulla of the bone. The fat will be released into the circulation. Sudden overload of the fat will cause the embolism like symptom in our body. Okay, first thing. Next, what are the triad of the symptoms? The triad will be mostly rash, okay, and also patient will be having the tachypnea and sometimes coma or depression will be seen. So these classically sudden symptoms will be presented in the patients of the fat embolism syndrome. Next, how can we diagnose this? Is it present in the less than 24 hours or how? So usually this is going to be presented in the less than 24 hours. Okay, next, there is a specific criteria that we can use that is known as a GERDS criteria. Okay, at least if you know the name, that is fine. That is known as a GERDS criteria. Next, treatment, you have to give the always related to the supportive treatment only. Okay, supportive treatment and underlying cause, this femur fracture should be treated as soon as possible. Next, other complication can be compartment syndrome. Okay, other complication can be compartment syndrome. So what is mean by the compartment syndrome? Usually compartment syndrome is due to internal or the closed fracture. Okay, so when there is a closed fracture, it will cause the pressure inside. Okay, all the nerves, arteries and related and surrounding structures will be compressed. This will cause the significant damage. How much pressure? Almost more than 30 mmHg. This pressure is going to cause the compartment syndrome. What are the symptoms this patient will be presented? Pain, and also this is the most important sign. Puffiness means swelling will be seen, and also due to compression of the vessels, pallor will be seen. Nerves are compressed, paresthesia, and over the time these nerves are compressed. This can cause the damage, so that will lead to paralysis as a late sign if it is untreated. And also pallor is due to arteries are involved, and along with that there will be pulselessness, right? So arteries is compressed, pulseness is also seen in this patient. These are the symptoms that is going to present it. Next, what is the treatment protocol for this patient? Immediate fasciotomy should be done in the emergency OT. That is the first thing that you have to do for this patient. Next, and also underlying cause that you have to treat. These are the some of the factors that you have to remember about the compartment syndrome. Next, you have to understand difference between the non-union and then malunion. So what is mean by the non-union? The name itself telling that the fracture is happened and failed to unite, right? It is failed to unite. Commonly seen in the scaphoid fracture. Okay, commonly seen in the scaphoid fracture. So in the non-union, there is no union will be seen. So that means no callus formation. Okay, no callus formation will be seen in this patient. So there will be abnormality, right? There will be abnormality that is going to be present. And next, on the X-ray, you are going to see the sclerosis and also gap between the fracture site. So there is a gap between the fracture site. Next, coming to the malunion. So there will be malalignment, or we can also say the wrong position. So the fracture is going to heal, but it can cause the wrong position. So this is known for the malunion, and obviously there will be a deformity is present, and here this wrong position is also due to callus formation. So the callus formation is also seen in this patient, and on the X-ray also you are going to see united bone fragment will be seen. Okay, united bone fragmentation will be seen here. Next, what is the most common type? The Smith fracture. Okay, the Smith fracture is the most common type for the patients, those who are with the malunion. So this is the common difference between the non-union and the malunion. Next, we are going to discuss about the some of the fracture eponyms. So these fracture eponyms are going to be very important, guys. For example, let's see here. You can see what are the types. First, the Bennett and the Rolando. So what does mean by the Bennett and the Rolando? These two are due to thumb base deformities. Okay, these are going to be thumb base fractures. So both are thumb base fractures only. So in the Bennett and the thumb deformities, so what happens here? What is the difference that you have to remember in this types? For example, if it is comes to the Bennett type, so this is most commonly it is going to involve the both are going to involve the what is the metacarpal that is involved? First metacarpal base, right? First metacarpal base. But so in the Bennett's, what happens? There will be a small olar ligament, or sorry, small olar fragments. It is attached only. Okay. Still, this fragment is going to be attached. Okay. The olar or ulnar fragment is attached. Next, coming to the Rolando, what happens? There will be a 2 to 3 fragments. Okay, 2 to 3 fragments is going to be presented. Next, what is the common muscle that is going to be displaced here due to this Rolando and Bennett? That is APL muscle. Okay, that is APL muscle. Okay, abducens pollicis longus muscle is going to be involved here. Next, moving on to the another picture here. So what is this picture, guys? This is known as a Bohler's angle. This is known as a Bohler's angle and also known as a Bohler's fracture. So what is this Bohler's fracture? Usually when there is a jump from the height, that is going to cause this fracture. Okay, this is the Bohler's angle. This is the common location for the fracture, and below or the behind the calcaneum you are going to see this fracture. Next one, here you can see these two fractures. So what is this fracture that we are seeing here? This is known for the boxer fracture. This is known as a boxer fracture. Commonly this boxer fracture is going to be involved the fifth metacarpal, and next this is known as a stress or the march fracture. Okay, so what is mean by the stretch or the march? During the over the time of the standing or doing the army people marching, they are going to have this second toe that is going to be involved here. So that fracture is seen in the stress and the march fracture. Next, here you can see this is known as a lower fracture. Okay, this is known as a lower fracture. So that means this is calcaneal fracture. Okay, this is calcaneal fracture that will be seen in this patient. Okay, next moving on to the types of tractions. So this is the simple skin traction that we are going to see, and this is the gallows traction where 90 degrees we are going to place the baby. And next this is the skin traction kit with the bandage inside too, and here the buttocks are lifted with the cot matrix. This is the different type of the gallows traction, and this is known as a Thomas splint. Here also you can see this is known as a Thomas splint to stabilization before the surgery. Next, coming to the some of the splints that you have to remember. So what is this splint that known, guys? This is known as a Nog-Benter splint. Okay, Nog-Benter splint. So in which patients we are going to use this one? Usually used in the claw hand. Okay, for the ulnar nerve injury, we are going to use this Nog-Benter splint. Next, coming to the another type here, this is known as a cock-up splint. This is known as a cock-up splint, usually used for the radial nerve injury. Okay, radial nerve injury. Next, here, this one is known as a Milwaukee. Okay, Milwaukee brace, commonly used for the spinal. Okay, spinal fracture or the spinal stabilizations. Next, this one is known as a Tyler's brace. Okay, this is known as a Tyler's brace, usually used for the patients of the TB spine or the Pott spine that we know. Next, coming to here, this is known as a Boston brace for the patients of the scoliosis, for the stabilization, and to move the malalignment, we can use this Boston brace. This one is the aeroplane. This is known as a aeroplane splint, used for the patients those who are having the brachial plexus injury. brachial plexus injury. Okay, these are the types that you have to take note and what are the important fractures. Next, moving on to the tumors. So in the tumors that you have to remember, first, what is the most common overall? So the most common overall is going to be metastasis. Okay, metastasis is going to be the most common. So from where? Most commonly from the breast and also most commonly from the prostate. So these are the common sites to get the metastasis of the tumor. But if they ask the what is the most common type of the malignant bone tumor, then if it is a true overall, then it is metastasis. But if it is only malignant tumor and metastasis is not given, then you have to choose the multiple myeloma. Then you have to choose the multiple myeloma as a choice. Next, what is the most common bone benign tumor? Then if it is a benign tumor, then answer would be osteoid osteoma. Okay, osteoid osteoma is the most common benign tumor. Let's see the differences between all the given following. Next, what is the things that you have to remember? Whenever you are going to see the patients, those who are coming from these tumors, the first thing that you have to remember is where they are going to be associated. Okay, first thing, the difference that you can remember is this way, guys. Okay, first here the most of the tumors which are arising from the epiphysis, okay, whichever is arising from the epiphysis, the mnemonic for this is ECG. Okay, ECG. What is this? First, E for epiphysis, E for epiphysis, and next C and G, these tumors will be arising here. The C for chondrosarcoma. Okay, next G for giant cell tumor. Okay, this is the one mnemonic. Next, remaining whichever are associated for the metaphysis. Remember this way, M O O D I, okay, B C. So what is this mnemonic? MODI BC. Okay, this is how you can remember. So M for metaphysis. M for metaphysis. O for osteosarcoma. Another O for osteochondroma. Next, this D and I just for the mnemonic basis only, and B for bone cyst, simple cyst or the aneurysmal cyst. Next, C for chondrosarcoma. And remaining, whichever is not coming from the epiphysis and the metaphysis, obviously they are arising from the diaphysis. Okay, remember this mnemonic, easy to recall if they given the X-ray for you. So don't have to be much confused when you are doing this, when you are solving this question. Okay, so let's start the discussion. So the first one here we are going to discuss is the osteoextososis. This is also known as a osteochondroma. This is known as a osteochondroma. And where this is arising, guys? This is arising from the metaphysis. Okay. And this is the most common type of the benign tumor. Okay. This is the most common type of the benign tumor. Next. Also, another thing that you have to remember, if they are progressed, they can convert into the chondrosarcoma. But here I said the benign tumor is the osteoid osteoma. So this is true benign tumor. Okay. Next, osteoid osteoma. This is arising from where, guys? This is actually arising from the diaphysis. We didn't included this in the mnemonics, right? So this is arising from the femur diaphysis commonly. Here the picture that you can see. Next, what happens here? So this is the lesion that is present. Commonly, the patients, those who are young, okay, less than 20 years of old, they recurrently they are going to have this pain. So these will be seen, the pain will be seen especially in the night, and if they have taken the NSAIDs, so the pain will be relieved. So this is the classical history that you are going to see. On the X-ray, you are going to see this nidus. Okay, less than 2 centimeters nidus is seen. So what is the treatment? You can excision and grafting should be done for this patient. Next one, enchondroma. So these enchondroma is usually most commonly known as a tumor for fingers. Okay, tumor for metatarsals. Sorry, metacarpals. And associated syndromes like Maffucci syndrome. Okay, associated with the Maffucci syndrome and also Collier syndrome. And what are the other things that you have to remember about the enchondroma is this is going to be the very commonly associated with the 40 years of age people. Okay, 40 years of age people, and if they are converted to the malignant, again they can highly risk to form the chondrosarcoma. Okay, they can develop into the chondrosarcoma. This is the classical picture of the enchondroma and multiple tumors that is presented. Next, here you can see this is the giant cell tumor or the osteoclastoma, and this is where it is seen, guys. It is seen in the epiphysis commonly. Okay, epiphysis distal femur we are going to see on the X-ray. You are going to see classical appearance, so bubble appearance, and also it can be called as a eggshell appearance will be seen in this patient. So treatment will be they are highly metastatic and also can cause the metastasis to lungs and locally aggressive also. What we can do for this, extended curettage should be done. Okay, extended curettage should be done for this giant cell tumor or the osteoclastoma. Next, moving on to the malignant tumor. In the malignant tumor, the most common what we discuss metastasis, and other if that is not given, then you have to choose the multiple myeloma. Then osteosarcoma. Osteosarcoma is on the X-ray. You are going to see this two kinds of the signs. So this is known as a Codman's triangle. This is known as a Codman's triangle, and this is known as a sunburst appearance. This is known as a sunburst appearance. And another points, remember, this is most radiosensitive tumor. Most radiosensitive tumor. Sorry, this is the most radio resistant, guys. Correction. So this is most radio resistant tumor, and it can be associated with the radiation. So if the patient is having the history of the radiation, they can be seen with the osteosarcoma, usually causing where is the lesion that is present in the metaphysis. Remember the mnemonic MODI BCC. Next, Ewing sarcoma. Ewing sarcoma is going to be involve the diaphysis. Ewing sarcoma is going to involve the diaphysis, commonly femur, and usually the chromosomes that is involved is the translocation 11:22. This is also seen, and whatever is positive here, the MIG2 CD99 is going to be positive marker. Okay, and on the X-ray, you are going to see this Ewing sarcoma as a onion skin appearance. Next, chondrosarcoma. Chondrosarcoma is going to be cartilage tumor, and these patient cartilage tumor will be chemo resistant. Okay, they are chemo resistant, and most common involved is pelvis is going to be commonly involved in this patient. Next, fibrous dysplasia. So the name, it is not a truly neoplasia, but the dysplasia is commonly right disorganized, and a continuous growth will be seen in the fibrous dysplasia. And what is this classical sign on the X-ray you call? This is known as a Shepherd's deformity. This is known as a Shepherd's deformity or the Shepherd's crook deformity. Most commonly involve the shaft of humor. Right? Over the time, it can cause this kind of deformity in the developmental age after 20 years. And on the histopathology, you are going to see the Chinese pattern. A Chinese letter pattern, bone cells are dividing here. So that is seen in the histopathology. Next, multiple myeloma. So as we discussed, this is the most common malignant type. This is the most common type of the malignant. And what is this skull that is called as, guys? Punch out lesions. Okay, these are known as a punched out lesions. And on the urine sample, you are going to see the Benz-Jones bodies. Benz-Jones bodies, and there will be a hemolysis also seen. So the patient will be suffering from the anemia and also rose vein formation, like clumping of the RBCs will be seen together. Along with that, there are Ig globulins, right? Immunoglobulins like light chains will be raised. Okay, light chains will be raised when you are going to do the test. Next, this is the multiple myeloma. Commonly, the patients will be associated with the back pain, right? These kind of the symptoms will be seen. Next, moving on to the classifications of some of the important. This is known as a Gustello-Anderson classification. So Gustello-Anderson classification for given as a three important types, guys. So the first type, it is known as a closed fracture. Okay, it is known as a closed fracture. So most commonly it is closed only. The skin wound will be less than 1 centimeter and simple fracture type. Next, class 2. So there will be a skin wound which is more than 1 centimeter and soft tissue damage is not that extensive. Next, third type is divided into the three types actually. So you can remember that this can be more than 5 centimeters, or there will be a severe crush injuries, or there will be a severe vascular injury. And these all lead to, this is known for the severe Gustello-Anderson classification. Okay, open type with contaminated. Okay, open type with contamination, that is seen with the classification 3. Next here, this is known as a Salter and Harris classification. So in the Salter and Harris classification, we have total 5. So what is this? This is going to example for us the physeal fracture. Okay, physeal fracture like growth plate fracture that you are going to classify. So for the first class, it is going to be just separation of the growth plate. Next, class 2. So there will be fracture, but it is above the fracture line, that is above the growth plate. So this is the growth plate, guys. So this is the epiphysis, this is the diaphysis, right? Next, class 3, it is below the growth plate. Next, class 4, through the growth plate. So the growth plate is also damaged here. Class 5, so there will be a aeration of the growth plate. So sudden the compression of the both epiphysis metaphysis causing the disturbance here in the growth plate. That is the fifth classification. Next, here you can see another picture. So this is known for the, what is this condition, guys? This is known as a osteonecrosis, or also known as a avascular necrosis. So avascular necrosis is most commonly associated with the trauma. Okay, traumatic is the most common cause. So on this picture here, you can see this femoral head, when there is a compression, when the neck of the femur is going to be here, the damage is here. There will be an artery that is passing here. So the compression is happened. So there is no circulation that is going here. So over the time, this calcification will be seen in this patient. So this is known as a avascular necrosis, or also known as a Chandler disease. Okay, Chandler disease. Next, what are the other causes for this patient? Usually steroid use. Okay, steroid use, sickle cell anemia, and also Parthes disease. This is avascular necrosis in the children, and also Gaucher disease. Okay, Gaucher disease, and also Caisson disease. Okay, Caisson disease commonly seen. Most commonly involved is going to be the femur. Okay, and other type, sorry, neck of the femur is going to be most common, and other one will be the scaphoid, like waist of the scaphoid will be involved, and next thallus. Okay, here also neck of the thallus will be involved. Next, what is that? Usually what happens in the patients, the investigation of the choice will be MRI, where you are going to see the changes, right? The dead bone appearance or the sclerosis will be seen. Next, what is the treatment? Complete replacement is the treatment. Move on to the next discussion. So we are going to discuss here about the fractures. Okay, so first here you can see this is the commonly known for the clavicular fracture, right? This is known for the clavicle fracture. So what is the common location for the clavicle fracture, guys? So it is between the junction of medial and lateral. So but how much from the each side? So the junction of the medial is 2/3 and lateral 1/3. So this is the common location for the fracture of clavicle, and this is the most common fracture overall. And what is the treatment? So 8-shaped bandage will be applied as a prophylaxis that we can do for the formation or the callus formation for this. Next, here you can see this is known as a supracondylar fracture, right? This is supracondylar fracture. Supracondylar fracture that is seen in the children, right? Commonly associated in the children. So where this is mainly, usually this is the humerus, right? This is the humerus. This is the distal. So the distal humerus, these are the condyles. So above the condyles, that is known as a supracondylar fracture, commonly seen in the children population. So what happens? There is a two types. One is extension type and other one is the flexion type. So the most common will be the extension type. And what happens? This is due to like like overstretching of the hand, which will be causing the supracondylar fracture. And what is the artery that is involved here? That is brachial artery. Okay, the brachial artery is going to be involved. And what is the nerve that is involved? There are three nerves are going to be involved, but most common will be anterior interosseous nerve. Anterior interosseous nerve, and other than that there will be a radial nerve and also ulnar nerve is going to be damaged. Okay, these are the two types. Next, coming to the complications. What are the complications that you are going to see? These complications is known as a gun stock deformity. Okay, gun stock deformity seen in the supracondylar fracture. Okay, these kind of the when the deformity is going to be formed the like valgus. Okay, the cubitus valgus. This is seen in the supracondylar fracture. Next, we have the other two types like Monteggia fracture and the Gallisi fracture. So what is the difference between the Monteggia and the Gallisi? So the fracture of Monteggia will be at upper one third of ulna plus proximal fracture of 1/3 to the right ulnar junction is going to be disrupted. Okay, this is seen in the Monteggia fracture. Next, here, this is fracture of radius. Okay, this is radius fracture with the distal ulnar junction disruption. Ulnar junction disruption that is seen in the Gallisi fracture. And the nerve that you have to remember, the Monteggia will be involving the posterior interosseous nerve. Next, what is the difference between the Colles and the Smith? Colles is going to be the more common. And what is the here? The deformity here is it look like dinner fork. Okay, it look like dinner fork deformity. Next, in the Smith fracture, it is going to look like a garden spade deformity. No. So in the Colles fracture, usually the fracture is involving the wrist. Where is the location? The distal radius fracture, which will be involving the dorsal displacement. Okay, dorsal displacement. Right here, this way. Right, this way you are going to see dorsal displacement. Opposite to this is going to be same distal radius fracture. But the displacement will be in the olar or palmar side. palmar displacement here like this, right? Palmar displacement. So that is seen in the Smith fracture. Okay. Next, moving on to the dislocations. Okay, the primary posterior hip dislocation and the anterior hip dislocation. Which is most common? The posterior dislocation is going to be the most common type. So what are the causes? Usually those who are suffered from the dashboard injury from the vehicular, and those who are having the fall from height. This is seen with the anterior hip dislocation. Next, the mnemonic that you have to remember for this will be the FADIR. Okay. Next here, FABIR. So what does mean by the FADIR? When there is a dislocation, the attitude of the limb will be flexion at hip, and abduction. So this is the adduction of the thigh, and IR for the internal rotation. Next here, FABIR, the flexion at hip, which is common, but abduction at thigh and external rotation. Okay, external rotation, that is seen. So here the length of the, when the posterior dislocation, the length will be shortened, and here it is going to be lengthified. It is going to be lengthened. That is seen with this both types of the dislocations. So this is the X-ray, right? Posterior dislocation. Okay, the posterior dislocation is going to be seen this way. Next, here anterior dislocation, where you are going to see there will be, like, the dislocation will be on the anterior side. So the abduction, right here you can see this is going to be the abduction, and external rotation, here it is going to be the internal adduction, right? This is the difference between the both types of the dislocations. Next, moving on to the Pott's spine. Okay, in the Pott's spine you have to understand what is the most common cause for the Pott's spine, guys. Tuberculosis. Okay, tuberculosis is the going to be the most common. And the things that you have to remember about the Pott's spine. So what is the common location that is involved here? So it is going to involve the thoracic. Okay, it is going to involve the thoracic region. This thoracic region is going to be caused the, how the symptoms will be presented. What happens here? So the patient will be having the common symptoms like fever and weight loss, night sweats, back pain. Okay, these common symptom is chronic back pain. Okay, so when they show this chronic back pain, so what happens over the time? They will destruct the vertebral bodies. Okay, they are going to destruct the vertebral bodies here like this. So the destruction and fusion will be seen of this vertebral body. And what is this deformities, which will be known as gibbous deformities? Okay, gibbous deformities. And over the time they can also cause the abscesses. Okay, psoas muscle, and this will be causing the paraplegia. Okay, like army stiffness. And investigation of the choice will be MRI. Investigation of the choice will be MRI with histopathology. This is the gold standard, right? And treatment, again, anti-tubercular therapy for at least 1 year we should give for this patient, right? This is the main thing that you have to remember. Next, coming to the osteomyelitis. Osteomyelitis can be acute, subacute, and chronic. Less than 2 weeks is going to be the acute. More than 6 weeks is more than 6 weeks is chronic. Between the 2 to 6 weeks is going to be the subacute. In the subacute only, we are going to see the Brody's abscess. Okay, and in the involucrum and sequest formation is seen in the chronic. And in the acute type, what are the causes? For the children and adults, most common with the Staph aureus and sickle cell disease. Salmonella, IV users, Pseudomonas, animal bite, Pasteurella, human bite, Echinella, and neonates is going to be group B Streptococcus or the E. coli. So these are the points that you have to remember about the osteomyelitis. Next, septic arthritis. So this is going to be the inflammation of the joint space. Okay, joint space. What is the most common joint that is involved here? Knee. So what are the symptoms that you are going to see? Erythema and severe tenderness and arthritis, which will be causing the inflammation. So the fever and other systemic diseases also seen. But what is the most common cause here? The most common cause will be staph aureus. Okay, most common cause will be staph aureus. But those who are suffering from the STD, that is going to be the gonorrhea. Okay, gonorrhea is most common in the sexually transmitted patient. Next, IV drug abusers, again Pseudomonas will be the common cause. Next, what is the treatment of the choice here, guys? The treatment of the choice will be arthrocentesis. Okay, arthrocentesis. So this can be both treatment and also diagnostic. So both samples can be taken and removed through the arthrocentesis. And on that, you are going to see the increased WBC count and also neutrophils. So that predominantly make us the diagnosis of the septic arthritis. And if this septic arthritis seen in the children, again this is also going to be the staph aureus, but this condition is known as a Tom Smith deformity. Okay, Tom Smith arthritis. So the Tom Smith arthritis, with which is the joint that is going to involve here, hip is the most commonly involved in the children. Okay, this is the septic arthritis. Next, here you can see this is known for the Kippel-Fell syndrome. So what is this Kippel-Fell syndrome, guys? So here the picture you can understand the patients, those who are suffering from the Kippel-Fell, is actually due to defect in the cervical spine. Okay, the defect is in the cervical spine. So what are the common features that they are going to have in this one? There will be webbed neck. There will be webbed neck. Along with that, short hairline, short hairline, and also restricted neck movements. Okay, they cannot shift to the sides, that is known to the restricted neck movements. Along with that, if you can see this the observation, so the patient will be associated with the scoliosis also. Okay, scoliosis will be also seen. This is seen with the Kippel-Fell syndrome. Okay, next, what is this picture, guys? This is known as a osteogenesis imperfecta. Osteogenesis imperfecta. So these osteogenesis imperfecta patient, how they are going to be presented? What is the triad that is seen? Usually this is due to COLA1 gene mutation. COLA1 gene mutation due to collagen 1 defect, right? They are going to be presented with the bone fractures, recurrent bone fractures will be seen, and also blue sclera will be seen in this patient, SNHL, and dentition defects. Okay, dentition defects will be also seen in this patient of the osteogenesis imperfecta. This is autosomal dominant condition. Next, developmental dysplasia of the hip. So these tests are known as, this is known as a Barlow test, and this is known as a autonomy. So autonomy is out. Okay, remember this way. Autonomy is going to be outside, whereas Barlow is going to be the inside. That is a common differences that you can remember. So these developmental dysplasia, okay, developmental dysplasia of the hip. So what is the common cause for this developmental dysplasia? Usually in the organogenesis. Okay, usually in the organogenesis, those who are having the malpresentation or those who are having the subluxation, okay, during the birth, if they are having the subluxation, so this is going to be the deformity. Especially which patients we are going to see? Breech babies, right? This breech babies will be having. And over the time, what happens? They are going to be that femoral head this like. So there will be inequality will be seen. So the length discrepancy, asymmetrical and restricted movements of the abduction will be seen with the patients. Okay. So the short limb Okay, the short limb and asymmetrical and leg length will be depressed. And these patients, those who are having this dysplasia, no, they also not going to have the femoral pulse. Okay, to the defected side, there will be femoral pulse is not going to be present. So this is also one of the features that you have to understand. And the patients, those who are less than 3 years old, we are going to perform this Barlow and Ortolani test. But whatever the patients, those who are more than 3 years old, for them, there we can where we are going to see the guide abnormalities. For example, Tredelenburg Giant will be seen in this patient, and investigation of the choice will be the ultrasound. Okay, and ultrasound is going to be our investigation of the choice. Next, what is the treatment of the choice? Usually we can go for the like Paulic grip. So the Paulic is can be done Paulic maneuver. So I added the picture. I will see. Yes, here. So this is known as a Paulic splint. Okay, this Paulic harness will be given for the patient, those who are less than 6 months. Okay, this is for the betterment. And for those who are more than 6 months, we have to do the reduction surgery. Okay, we can do the reduction surgery, and more than 3 years old, where we can do the pelvic osteotomy, like shape changing of that affected limb. And if it is more than 10 years, then hip replacement only the choice. Okay, that is the first thing that you have to remember. Next, here you can see this is the condition of osteoporosis. What happens in the osteoporosis? The bone mass is going to be decreased. So why this is going to be? This is due to decreased mineralization. Along with that, the whatever the bony structure is damaged. That is why is causing the osteoporosis. This is how the specimen of the osteoporosis will be looking. And most common cause will be the obstetric cause only. Okay, the most common cause will be obstetric, and female post-menopausal women will be seen. And those who are taking the steroids will be seen. Those who are taking the heparin, and also smoking, obesity, okay, age, alcohol, all this will be associated with the osteoporosis. What is the best test that we can do for this patient? The best test for this patient is the gold standard DEXA. Okay, DEXA is done. And if it is DEXA less than 2.5, okay, then it is confirmatory for the osteoporosis. And treatment of the choice and drug of the choice will be bisphosphonates. Okay, bisphosphonates. They are going to act on the osteoclast for the bone resorption. Okay, for the bone resorption, they are going to act. And also teriparatide, where parathyroid hormone analogs can be also given for this patient. Right? These are the some of the treatments that we can give. And what is the common thing that is associated here? Fracture. And what is the common location? That is going to be vertebra. Vertebra is the most common, followed by hip, and then Colles fracture. Okay, these are the overview of the osteoporosis. Next, this picture here you are going to see about the osteopetrosis. This is osteopetrosis. So this is also known as a marble bone disease. Okay, this is known as a marble bone disease. What about the brittle bone disease? This is known as a brittle bone disease. This is brittle bone disease. Now we'll see the osteopetrosis. This is due to osteoclast, okay, overproduction. Okay, overproduction. So over the time, what happens? There will be more bone density. Okay, more and more bone density. Eventually, there will become the fragile. Okay, eventually there will be becoming the fragile and more opaque. Okay, more opaque, or the opacity is seen, and this fragileness will be risk of fractures. Recurrent fractures will be seen. Along with the osteopetrosis, this is also autosomal dominant. The patient will be associated with the hepatosplenomegaly, okay, hepatosplenomegaly and pancytopenia, pancytopenia, and also SNHL. Like these symptoms also seen in this patient. This is known as a marble bone disease. Next, this is known as a Paget's disease. Okay, this is known as a Paget's disease. And in the Paget's disease, not just osteoclast, there will be both. So osteoblast. So both they are going to be cause the increased bone remodeling. So that will be causing these kind of symptoms. So the patients will be increased head size, okay, due to disturbance in the bone resorption or the bone remodeling, and eventually what happens, the bone pain and severe vertebra pain will be seen. So this patient normal calcium and phosphorus, but increased ALP and normal parathyroid hormone will be seen. Okay, and this is feature is known as a cotton wool or Pott skull appearance. Next one, brown tumors. So this is known as a brown tumor. Brown tumor is seen in which condition, guys? Usually associated with the primary hyperparathyroidism. Okay, primary parathyroid hyperparathyroidism. In this patient we are going to see. So what is the common feature here? There will be deposits. These deposits is due to osteoclast. Okay, osteoclast proliferation, which will be leading to the hemosiderin. Okay, hemosiderin deposits will be seen. That's why this brown color name is kept. This is associated with the brown tumor. And what is the values that you are going to see here? Parathyroid hormone will be increased. If it is increased, calcium will be increased, phosphorus will be decreased. Right? This is how we are going to see. And these lesions is known as a lytic lesions. Okay. Next, this is known as a Martel sign, and where Martel sign is seen in the gout patient. This is tophi, or this is due to deposits of gout. Okay, monosodium crystals. Martel sign seen in the gout patient. What happens here? There will be subperiosteal bone resorption will be seen here. Next, coming to the some of the other, this is known for the rickets, right? This condition is rickets. So rickets is commonly associated with the vitamin D, okay, vitamin D deficiency, right? This is acquired, commonly seen in the children, and this is most common cause for the genu valgum, genu varum, and also Windschaft deformity. For all the complications, the most common in the children will be vitamin D deficiency rickets only. So these patients, the features will be craniotapes, okay, and rachitic rosary, like budding in the subchondral region, and also bowing of legs, okay, the failure to grow, failure to thrive, that is seen. On the X-ray, you are going to see this feature, splaying, cupping, and fraying. Okay, this is known as a slaying, this is fraying, and this is cupping. Okay, these are the features of the rickets. Next, this is known for the CTEV. Okay, this is known as a CTEV. So what is this condition, guys? CTEV. So the CTEV is commonly, again, this is also going to be the childhood deformity. So commonly what happens in this patient, those who are suffering here, this is known as a Talipes equinus varum. Okay, varus. So like this. So the commonly the babies will be having these kind of anomaly in the foot. Okay, 50% of the cases will be bilateral only. Okay, most of them will be bilateral, and males are going to be affected here. And what happens here? The common cause will be idiopathic only. Okay, common cause will be idiopathic in this patient. But over the time, there will be only causes of adduction and varus will be seen. So what happens here? The joints that is present here will be eventually habituated to these kind of the varus position only. So that's why what we can do for this patient is first go for the investigation of the choice. So this can be done with the X-ray. And on the X-ray, you are going to see the angle. What is that angle, guys? Thalocalcaneal angle. Thalocalcaneal angle will be seen in this. So normally, if it is less than 20 degrees, then it is considered as a club foot. Okay, it is considered as a club foot. And treatment of the choice will be started within the 2 weeks. Okay, whenever from the diagnosis, you are going to start the treatment with the help of the cast or with the help of the Ponset method. Ponset method. Okay, this is how. And these are the splint. The splint is known as a Dennis Brown splint. Dennis Brown splint we are going to use in this patient. Okay, next moving on to the Parthes disease. So Parthes disease is also known as a avascular necrosis, especially in the children. Right? In the children, sickle cell anemia or those who are suffering from the immunodeficiency and those who are associated with the fracture disorders like recurrent fracture disorders will be seen. Arthritis. Most common joint that is involved here is the femoral. Right? Here you can see the dead bone of the femoral head will be seen. Next, this condition. So this is known as a osteoarthritis. Okay, degenerative condition. And what are these features, guys? This is these two are different nodes that is present. So this is known as a Heberden nodes, and these are known as a Bouchard nodes. Bouchard nodes. Complication seen in the pip joints. These are seen in the dip joints. Okay, HD and BP. Remember that way. Next, this is seen in the rheumatoid arthritis where positive anti-CCP and seropositive condition. What is the complication? Ulnar deviation will be seen and quaternary defect and also swan neck deformity will be seen in this patient. Right? These are the some of the features that you have to understand. And more overview of the osteoarthritis, rheumatoid arthritis is said in the medicine part 1 lecture. So this is the overview and important part of your today's lecture in the orthopedics, guys. So please do revise these topics and don't forget to practice tonight MCQs. Those who are new to this channel, please do subscribe and share with your friends. Until then, happy preparation.